Good morning or good afternoon. Thank you for joining us. This is the National Consortium of Telehealth Resource Centers Telehealth Hack Series, Building Accessible Telehealth for Patients and Disabilities from the Ground Up. My name is May Kwong. I'm the Executive Director of the Center for Connected Health Policy, which acts as the administrator for the National Consortium of Telehealth Resource Centers. Next slide, please. National Consortium of Telehealth Resource Centers is presenting to you this Telehealth Hack Series. Please note that data that we may collect from your registration will not be used and will be kept confidential. We will only use it for certain reports or communications that we may have with HRSA, but any information is kept confidential, so please do not worry about that. Next slide, please. National Consortium of Telehealth Resource Centers is made up of the 14 telehealth resource centers who are funded through a grant from HRSA. There are 12 regional resource centers that cover specific states and 2 national centers, one that covers policy and one that covers technology, but all 14 work collaboratively together on joint projects. Next slide, please. Some of you may be familiar with the Telehealth Hack Series that was actually begun by ASPR. They began it back in July through September of 2020. However, it was for only a limited time. Due to the popularity of the program, the Telehealth Resource Centers were asked to take it over, and we have since done that. Our first webinar was actually last week based on technology, and we will continue the series through March of 2021. Next slide, please. A couple of tips for our session today. So please know that your phone or computer microphone has been muted. We ask that you put any questions that you may have for our speakers in the Q&A function. The chat function is merely for technological issues that you may have with Zoom. You're able to adjust your video sizing on the Zoom using the sliding feature. If you can, and you actually need to make some video larger because we do have an ASL interpreter today, you can move the middle toggle bar to make the videos bigger. Also know that we have a closed captioning button on the bar if you prefer that other type of means of getting information. Know that today's webinar is being recorded. However, due to certain limitations, we will not be able to record the Department of Justice session. However, the PowerPoint for that presentation will be made available afterwards. And also they will provide information on how you can reach out to certain members of their department for technical assistance. Recordings will be posted on the NCTRC website and YouTube channels, and those are the links to that. Next slide, please. So we are offering CE credits for the session today, and the next couple of slides will tell you how that information can be downloaded if you are interested in getting credits. It is through the University of Arkansas Medical Center. Next slide, please. These are certain disclosures that we had to make, so we'll just go to the next slide. And then the next slide. So this is the information you're probably interested in if you're interested in the CME credits. So evaluations must be completed by October 20th. If you do not complete the evaluation by this deadline, could you please go back? You will not receive continuing education credits for this hour. Next slide, please. That is the access code that you will need to receive your credits. Next slide. And this is other information that you will need and how you can access the ability to download the application to receive credits. And this is also going to be available on the slide deck if you did not catch that information the first time around. So today we will start off first by having a presentation from Dr. Jent, and then the Department of Justice will go next, and then we will have a recorded presentation by Dr. McKee. So right now I am going to turn it over to our moderator, Dr. Christian Reimers, who some of you, again, may be familiar with if you were with us for the ASPR webinar series. So Dr. Reimers is the Chief of Population Health and Director of Graduate Medical Education at the Family Health Centers in San Diego, a large federally qualified health center system serving nearly 200,000 medically underserved individuals throughout San Diego County. He is board certified in internal medicine, infectious diseases, and addiction medicine, and is particularly interested in HIV, HBV, HCV, and serves as medically underserved immigrant and refugee populations. Dr. Reimers?
Thank you so much, May. It's good to be with you. Good morning and good afternoon to everybody here. We have a great session planned for you today, and we're going to follow the format as May indicated in the slides there of a case study, followed by a didactic, and followed by another case study that in this case will be recorded. So I wanted to thank everybody that's involved to help make this work, and also thank those who are behind the scenes answering questions. Please do feel free to use both the chat if you have any technical problems or the Q&A to send your questions directly into the panelists for having them answered. I also want to make a quick note just to say that we're trying to maintain a really open and welcoming learning environment. We'd like to keep everything non-commercial and non-political. And then please do respect the limitations. I don't think yet had any attorneys from the Department of Justice in any of our TM hack sessions. And as you probably know, there are things they are able to answer and things they aren't. So please be respectful of that as well. So without further ado, I'd like to introduce our first speaker that'll be talking about our first case study. And this is coming from Dr. Jason Jent. Jason Jent is an associate professor of pediatrics on the clinical educator track at the University of Miami Miller School of Medicine. He serves as the Director of Innovation and Community Engagement and is the Director of Training for the Mailman Center for Child Development, their clinical psychology internship and postdoctoral training program. He's a licensed psychologist in Florida and joined the faculty in 2007. And his research focuses on reducing disparities related to access and the efficiency of behavioral interventions for children's disruptive behaviors through the use of neighborhood-based technology augmented or driven and/or telehealth services. So Dr. Jent, over to you.
Thank you so much, Dr. Ramers. Next slide. So today I'm going to be talking to you about increasing reach and accessibility of telehealth services for children with disabilities during COVID-19 and beyond. Next slide. So at the Mailman Center for Child Development, we serve over about 15,000 children per year, and our center has a particular emphasis on serving children with developmental disabilities and or special healthcare needs. And we tend to do this across taking an interprofessional approach to our services, and we really focus on the domains of education, prevention, screening, assessment, and intervention, which I'll talk about those a little bit more in a few slides. Next slide. So prior to COVID-19, most of our services that were offered at the Mailman Center were really being delivered in an in-person format. So we had developmental and behavioral pediatrics where we had physicians providing medication evaluations and medication management. We also had a plethora of outpatient therapy services. We had a special assistive service and technology use lab where people could actually come in and check out low and high-tech AT devices and get assessments on how to use those and actually get training on how to use those before they would take those devices home. We also have an audiology clinic and a hearing loss clinic and a cochlear implant clinic where most of these services were provided in person. And we also have speech and language pathology built in. So we are very much a broad center with lots of different services. We're also providing psychoeducational evaluations. Some of our services, more in the psychology domain, we're providing services already via telehealth. And that was happening within one of our parenting programs. So we have a parenting program called Parent-Child Interaction Therapy, where it was a live coaching model of treatment where we would actually coach a caregiver on how to talk to their child and communicate and play with their child through a one-way mirror. They'd be wearing an earphone or we'd be talking to them on the other side with a microphone. So that just translated really well to telehealth already. And then we also have a school-based primary care program where we have a group of behavioral health professionals that are providing behavioral health services to 9 different schools in Miami-Dade County. So we use telehealth as a way of increasing reach with that population. Next slide. So when COVID hit, and it hit Miami pretty hard, like a lot of other places, we really were moving to transition a lot of these exclusively in-person services to telehealth during a stay-at-home order. And we really ramped up this very quickly over a 72-hour period where we made the decision that we were going to take our services that were in person and begin to provide them via telehealth. And because we only had a subset of clinicians that were already experienced in providing telehealth, we really had to use them as leads and experts to help build the capacity of all the providers that had no prior telehealth experience. So one of the ways that we really focused on doing that within our program was through session and appointment simulation, so just getting them used to the video conferencing software that we were using. but also simulating common things that might happen as it relates to tech issues, or even simulating aspects of what the actual session would look like for the families. We also developed a center-wide telehealth community of practice where we could share some of these ideas about, if we're going to be delivering these services, how can we do it well? And one of the things that we learned through that process was common ways to engage families, common ways to troubleshoot tech, and also common ways to kind of make the intervention more effective. And as that kind of grew, then we realized it was best to move those communities of practice into a more specific domain. Also, we developed kind of written telehealth guides and also some video-based telehealth guides to assist with people with their training capacity. Next slide, please. So I'm going to take a moment and we're going to launch a poll, because I'm not sure how many people are actually familiar with the coaching model of telehealth for children, just to see who we have represented in the audience. We'll give it about another 10 seconds or so before we move on, and then we'll have the poll results shown. Okay, if we're able to show the poll results to see kind of what we have represented in the audience. All right, so a large portion of our participants today, 93%, have not had any experience. So I'll take a little time explaining that on the next slide. So when we think about a lot of our telehealth interactions that happen, especially for children with different kinds of disabilities or presenting concerns, is a lot of times that those interventions take place from a provider-child specific interaction. And what it does when we're switching to a coaching model is that we're switching to a format where the provider is actually providing coaching via telehealth to a caregiver to engage in the types of interactions that the provider would be doing with the child if they were delivering those services face-to-face or in person. So we've been able to do that as a part of some of our intervention services across different disciplines, but we've also done that as a part of some of our assessment modalities where we need to set up child observations and have children engage in particular tasks so we can engage in some type of assessment about a child's development. So essentially the caregiver begins to complete similar tasks that a child's provider would in person. And one of the benefits that can come along with that is the idea that the caregiver is learning the skills that the provider is using, so they're actually able to reinforce those skills in between sessions. And because we were able to make that shift, is we actually saw that some of our referrals during the beginning of COVID-19 actually increased because our service provision continued. Next slide, please. So some of our program highlights that we had, so as I mentioned previously, we had an assistive technology lab that was an in-person thing. And traditionally, this was something where we offered this in-person training and lending of that equipment. And essentially what we had to do, because we really wanted to make sure that these children were still getting access to low-tech and high-tech assistive technology devices, is we would actually pack up and do a contactless delivery of those items to the homes. And then we would also provide them with written materials as well as video materials for those AT devices. So they had that as kind of an on-demand resource. And then we'd actually provide them with a tablet as well as a tripod so that we can kind of do a telehealth visit with them and do unboxing and actually walk them through each step of the assistive technology device to make sure that they fully understood how to do that. The other thing is we were also, as I mentioned earlier, providing parent training, and we were providing parent training for one particular family who would actually walk to our clinic, and we were providing a service for the child who had vision loss and also had an autism spectrum disorder. And when we had to switch to just telehealth services, it so happened that this particular family resided in a homeless shelter. So they didn't have a private space for us to be able to conduct these telehealth sessions. And also the caregiver did not have childcare for their other child who also had autism. So what we had to do is we actually coordinated with the homeless shelter so they could create a private space for us to be able to conduct these telehealth sessions. We provided them with the equipment to be able to do that. And then we did a contactless delivery with all of the equipment and developmental toys that the family needed. And the family was able to progress significantly because of of this extra support that we're able to provide. Next slide. As far as our interpreter services, we have some physicians or allied health professionals that are on site that are kind of working within a setting where they're within a close enough approximation to other people that they have to be wearing a mask all the time. So our institution bought a number of clear masks. So when they are communicating with individuals with hearing loss, that they are able to see their lips moving during those communications. And the video conferencing platform that we utilize allows for us to actually do video remote interpreting. So we can actually join a call, and before we have a patient join the call, we're actually to do a call out and invite to an interpreter to be able to join the session. Then we can have the family join the session so that we have interpreter services from the very beginning of the session. Next slide. In terms of the telehealth written materials, a lot of the things that we do is we make sure that we're sending PDFs of written materials in advance of appointment or workshop. One of the things that we've found to be the most important part of the process for making sure that our services are effective is really making sure that families have all of the information that they need to be able to do the tech right, because if we can get the tech right, then we're able to deliver services much more efficiently and much more effectively, and we're not spending lots of time troubleshooting. Another thing we've done is we've tried to, when we're giving kind of more community parenting workshops, is avoiding lots of text boxes within slide presentations, which may make it difficult to for screen readers to capture all of those things. When we're providing one-on-one interactions and we're presenting any kind of thing on the screen, we want to be inquiring about the screen size and zoom in on our side as needed. And any videos that we're providing or sending out to families, making sure that there's in closed captioning, making sure that we have those things in the family's preferred language, and then also making sure that it's done with any hyperlink to videos. And any images that we're including in presentations or accessible PDFs that we're sending out, we're just making sure that there's alternative text for all images. Next slide. So when we think about just kind of movement towards increasing our accessibility of telehealth services, we know that children with disabilities are at highest risk for further disparities from their peers during COVID-19, especially if a lot of our early intervention services have stopped. And it's really key that we're figuring out how to, one, not only do telehealth services with these families, but able to do them well. And one of the things that we've built into our communities of practice, because I don't think that this is something that we built in early on, is really just making sure how we're building an accessibility training within our communities of practice for each specific domain of practice to make sure that our providers are able to do that well, and also just making sure that we're thinking about how this can be done for the families that are receiving services within each practice. Also, just to reduce disparities in terms of access to care, we're able to loan out, we have like 40 to 50 tablets that we're able to loan out, and we have mobile hotspots that we're able to loan out to families for the purposes of evaluations or services. And finally, just having computer companies are integrating more of their assistive technology device software directly onto the user's computers and their tablets, which does allow for us to do kind of a two-pronged approach to our telehealth training as it relates to AT devices, where they're able to do a share screen, but if we provide them with a tablet, we can also remote and see a share screen function of what they're doing, but also watch from behind their shoulder from a camera angle to kind of give them guidance, kind of what they're doing and how to make sure that that AT device is working the best for them in terms of helping with communication. Next slide. All right, so thank you for your attention. I'm going to turn it over to any questions that people may have.
Fantastic, Dr. Jent. Thank you for that. I see there's a little bit of discussion in the chat with difficulty finding the ASL interpreter. And I think if you just toy with the view at the top right of your Zoom window, you should be able to find the window of the interpreter and then perhaps pin that person so they will show up side by side. So on to just a couple of questions. I think we have about 2 or 3 minutes for questions. Dr. Jent, you mentioned that you loan out equipment to families. I think you said you have a sort of out-of-the-box session going over that. Can you talk a little bit about the logistics of that process and how it relates to the security of the devices and concerns about loss of the equipment?
Sure. So that's one of the main questions that we have people ask is like, well, don't your tablets get stolen or do they not get returned? And essentially we just have an equipment loan form that we provide them. Part of our kits that we provide them include a tablet, a few different mounts that we can mount the tablet to so that they have the opportunity to have different camera angles depending on what the need is for the session for us to be able to see. We also provide them with a Bluetooth headset, so they're able to talk to us directly, especially if we're engaged in some type of coaching model of telehealth as it relates to that. We've been loaning out these kits for about 3 years as one of our programs, and all of our tablets have been returned. If anything, we tend to lose some of our charging cables around the way, so you may have to budget additionally for getting some of those back. In terms of security, I think one of the things is just making sure you're restricting the settings on the tablets for those devices to make sure that you're limiting the apps that the family can be utilizing to complete those services. I think the other piece is that you really want to make sure you're setting up each tablet with its own account and unique password. If you set up the same account across devices and they're syncing within the cloud, you could have the potential for accidental sharing of photos or videos to the cloud, which could sync across devices, which obviously would be violating their protected health information.
Great, thanks for that. And what is the workflow to include translators in the visit itself?
Sure. So at our center, we use an external agency for that. And so we also, because we're in Miami, we use interpreters quite frequently. And so when we're scheduling the appointments for patients, the staff is checking in at that point to see if there's any need for any accommodations or anything that will help with the accessibility of the services. So if there was a need for interpreter services, that would be notated in the appointment notes at that point in time. At the start of the appointment, the patient would be held in a virtual waiting room on our behalf, and the provider is actually able to click on the participant section and do a call out to invite the desired interpreter for that service. So when we click that call out, we're actually able to select whatever the desired language is. So in Miami, we're doing that for Spanish and Creole, but it also could be for American Sign Language. And then we click the call. And then once the interpreter actually connects to our visit, we click done and we return to our virtual meeting. And then at that point, we would have the patient enter the virtual meeting for the session. So we make sure that we have that communication from the absolute start.
Great, and then just time for one final question. It's come up from several who have put it in the Q&A. Thank you for that, by the way. Everybody use the Q&A to submit questions. From Kristen Korinko and then also from Tony Davis, wondering about the platform. What video remote interpreting platform did you use?
So I know that we use an outside agency. I don't know the specific name of the company that we're doing, but I could probably check that during this and I can circle back and put it within the chat before the end of this talk, hopefully.
Okay, fantastic. Thank you so much, Dr. Jent. We're gonna move on for the sake of time. Appreciate it. And again, please submit your questions through the Q&A box rather than through the chat so we can track them a little more easily. But thanks again, Dr. Jent. So we're going to move on to our didactic presentation. And we are very, very privileged to have attorneys and staff from the U.S. Department of Justice with us. Remember that they are a little limited in what they can. Move on to a video presentation that's been pre-recorded by Dr. Michael McKee. And as Ray is getting his video queued up here, I'm going to introduce Dr. McKee in his absence. He's a family physician with clinical and research expertise in disability health. As a physician with hearing loss himself, he is especially interested in advocating for the rights of deaf and hard of hearing patients to obtain equitable health care, including accessible communication. His research focus has been on health disparities for individuals with various disabilities, health information accessibility, health literacy, and telemedicine applications. And Dr. McKee joins us from the University of Michigan Department of Medicine. So let's go ahead and start the video presentation.
Thank you, everyone. I'm sorry I was not able to be in person, but I'm honored to be part of this panel. I do hope that this pre-recorded session is helpful. I am also more than happy to follow up with any questions that may pop up by email. Today's talk is on COVID-19's impact on deaf and hard of hearing patients, identify the barriers and solutions to address them. I have two main objectives. One is to review how COVID-19 impacted the lives of deaf and hard of hearing individuals, including their healthcare access. And second, to identify techniques to ensure good access with virtual, telephonic, and in-person communication. So back in March, we had to quickly figure out efforts to ensure equitable access for our deaf and hard of hearing patients at the Deaf Health Clinic and also across Michigan Medicine. So our Deaf Health Clinic, which is housed at the Department of Family Medicine, cares for over 150 deaf signers and a much larger population of those who are hard of hearing. With the arrival of the pandemic, quick solutions were definitely needed to ensure that our care was both effective and accessible. The mandatory use of personal protective equipment and virtual care for everyone created a lot of communication challenges. And it's important to recognize that across our country, roughly about 15 to 17% of our population has a hearing loss. So we see these people everywhere and we see them often. So we need to make sure that we provide access for them. So what we did is develop a variety of protocols for both in-person and telehealth appointments to ensure that these people had good access. And we'll talk about these in detail later. So we're going to talk about healthcare access during COVID-19. So there were a number of media outlets that touched on this theme, how COVID-19 greatly disrupted communication access for deaf and hard of hearing individuals. Hospitals and designated clinics, we had many of them set up to manage COVID-19 patients, and many of them had varying restrictions, but a lot of these restrictions reduce the ability for deaf and hard of hearing patients to communicate easily. So obviously one that many people recognize is the use of a face mask. And so many of these restrictions, unfortunately, not a lot of thought was given on how to figure out solutions or ways to get around this. These safety procedures designed to protect patients and healthcare workers may interfere with accessible and effective communication, which is required by law by the Americans with Disabilities Act. So what we have seen over the past 6+ months is a widespread breakdown in communication across society. So even a simple trip to the food store is difficult for many of us, including myself, who has a bilateral hearing loss. And so while masking, we all agree, it's a critical tool to help reduce people's risk for COVID-19, but we also need to decide how we can mitigate many of these added on barriers or issues. So I wanted to talk about these strategies and think about ways we can disrupt what we have done in the past and think about new ways to ensure accessible communication with these patients. So virtual care appointments offers one way to avoid the masking situation. So if you're in working from home or some closed off facility, you could take a mask off, and this actually can be a way to help avoid the mask. But it's important to recognize that you need to have a 3-way video visit if you're going to have a either a hard of hearing individual that may need captioning, or if you're going to need to have an interpreter be part of the appointment, especially if you're working with a deaf signer. And so the 3-way video visits allow simultaneous addition of interpreters in this visit. And if it's not done, what ends up happening is that a lot of healthcare providers call their telephone number, which will default to an outside video relay service operator. This will lose the opportunity for the provider not only to see the patient, which is extremely helpful to see how they're doing, and also to develop a more meaningful relationship with the patient. And video relay service operators or interpreters are not trained for medical environments. They do not have the medical training and may not understand some of the medical terms that are used. So many large platforms such as Amwell, Virtual Health, we use Zoom. There's a HIPAA compliant form that you can actually subscribe to, and these all can provide 3-way video visits. One other benefit that we notice is that they're often used for medical student education as well. Preceptors, attendings can observe the medical students as they collect or interview patients. So this certainly has a technology that has multiple uses. So try to emphasize equity. So this is an example of me conducting a mock session, pretending I don't know sign and actually interviewing a deaf patient and having an interpreter below be part to facilitate communication back and forth. But it allows me to be able to see the patient, see how she's doing, and if there's any home situations that I need to be aware of. It's an incredibly rich source, and it provides a lot more data than just a typical telephone call. So keep in mind that deaf and hard of hearing individuals are quite heterogeneous, and they have different communication preferences. So some might actually request a video relay service operator if you're going to do a standard phone call. Some might require to have captioning through like a CapTel or other telecommunication device and be able to read out the message as you speak. Somebody's going to type that message out. Now, in terms of responses, some of them may speak back to you, some may type out the message back, and some might actually sign the message back. So most deaf and hard of hearing individuals will have these options set up so that when you call the patient, it will often default to one of these options. But if you do need to get a hold of the telecommunication relay service, you can just simply dial 711. But most patients have already connected their phone number to one of these options. But one thing I want to emphasize is that these are okay to use for standard phone calls. So if you're doing a lab update or a simple follow-up, but if you're communicating more complex things, just be aware that these are outside operators. These are not medically qualified people, and so you have to be on the lookout for possible errors as they type out messages. So you may want to just do some follow-up summary or even like a teach back kind of approach to make sure that the patient understands. While this is not telemedicine, I wanted to just briefly cover this because sometimes when we're doing virtual health or video visits from our clinic, we're wearing a mask. And it's important to understand that there are clear masks available. So we have two that are FDA approved. The first one is the Safe and Clear Communicator Mask. It's the first one that was approved. And the second one is the Clear Mask. Both of these masks offer a viewing window, so if somebody lip reads, they can see your mouth. It also allows better visual if there's expressions or other visual cues to help with communication. But keep in mind, these are not approved for highly aerosolized situations. So you need a powered air purifying respirator if you're going to do that. The above two do not work and they're not approved for those circumstances. The other concept that often is not really thought of as being part of the virtual or telehealth is that engaging combinations, so engaging our medical interpreters or even captioning or CART. So earlier in the pandemic with March through May, we were scrambling. A lot of our interpreters no longer could be there in person. And this was due to shortages with the personal protective equipment. And they also need to get trained how to use these equipment. So what we did is we quickly obtained iPads for mobile units, and this allowed ongoing interpret, but remotely from outside to allow accessible communication to take place between the provider and the deaf and hard of hearing patients. And we also were able to include CART. So this was the first time we were able to use CART quite often to help facilitate captioning services during provider and patient communication. But there are limitations here. So deaf-blind is a particularly hard impacted group. So this one really required to have interpreters be there in person because of the need for tactile sign. So a lot of the virtual or telehealth approaches does not work well for these groups. The other thing, there are a variety of other communication tools such as communication board, writing tablets, and even signage. This is to help improve not only the awareness, but help facilitate communication. These are rarely done, obviously, for telehealth or virtual, more in the in-person side. So I wanted to just demonstrate ways we're trying to be more proactive instead of reactive. This is an example of a fake patient to show how we can actually identify if the person has a disability, what type of disability they have, and what accommodations they need. And what this will do is allow for the healthcare team to understand early on what is needed, whether it's a three-way video visit with an interpreter or there's some additional steps that have to take place. And so this is a recent upgrade, so we're excited about this, and we'll be learning more as we go along. But it's important to really think about being proactive instead of reactive. Trying to quickly do a three-way video visit when at the time of the video visit appointment is too late. It's hard to try to get that accommodation set up. So try to be proactive, do it early on. That makes everything more smooth and will allow not only the patient and the provider to be happier too. And then lastly, I wanted to just emphasize that remember the patient is generally the expert on what works best with communication. And here are some helpful resources below. Thank you. Again, my apologies for not being able to show up in person due to a conflict, but I also wanted to encourage people, feel free to reach out to me and I'm happy to answer any questions. Thank you.
All right, many thanks to Dr. McKee for the pre-recorded presentation. We're just about at time, but I just wanted to bring in one question from the Q&A that comes from Carlos Nolasco. And actually, I'll send it to May here. The question is, can you recommend resources for small private practices or solo physicians that do not have a big infrastructure that can help them with resources?
Yes, thank you. So I would recommend first off that DOJ, they did provide, I believe, a TA number or a line in which you can actually ask questions of the Department of Justice. So that would be a great resource for you to use, but also use telehealth resource centers that will be able to help you at least look in the right direction on where you can access other resources if they do not have the resources themselves to answer your question. So those would be the two best spots to initially start with.
Great, May, and I'll put the web addresses to those resources in the chat and turn it back over to you to close the session out.
All right, thank you, Dr. Ramers, and thank you also to all of our panelists. That was a great session today. Apologies on the slight technical issue with spotlighting the interpreter. We did work that out, so apologies for the delay in that. Let's go to the next slide. Keeping on our legal theme, so for November, we actually have a legal series coming up. It will be presented for both sessions by Joseph McMenamin and Amanda Enyart. You might be familiar with both speakers. The first session will be on November 10th. It will cover licensure and patient-provider relationship. And the second session will be on November 18th, and we'll talk about liability and privacy. And then we'll also have another session in December and continuing on through March of 2021. So again, if you are looking for a recording of the session, it will be up within 24 to 48 hours on the Telehealth Resource Center's website. That is telehealthresourcecenter.org. Along with that will be the PowerPoint. There will be information on how to access CME credits in that PowerPoint as well, or you can send the questions to the TRC and National Consortium Telehealth Resource Center information box, and we will also be able to send you that PowerPoint directly or answer your questions regarding that. So thank you once again to our speakers. Thank you also to all of you who have attended this. Thank you, Dr. Ramers, for moderating the session. And we hope to see you on our next series in November. Have a great day.